Welcome to today's webinar. We have so many people coming from all over the world that I have to start this event with a good morning, good afternoon, or good evening, depending on where you are. My name is Branka Cupic, and I'm responsible for clinical content and education at Hamilton Medical, and I'll be your host today. The title of today's webinar, What Lessons Have We Learned Thinking About the Past 9 to 12 months, is quite ambitious. It clearly implies that we have learned something. But do we in fact have the recipe how to treat COVID-19 patients, or do we have even any recipe? We know that necessity is a powerful driver of innovation, and during the past months, we've been facing an enormous amount of challenges. Our knowledge of COVID-19 is constantly changing and evolving, and much of what we thought we knew or understood is turning out to be incomplete or even untrue. Today, we will focus on some of the controversies in respiratory care management that have arisen due to the COVID-19 pandemic. To discuss these, we are proud to bring you today 3 keynote speakers coming directly from the front line in the fight against COVID-19. We will look at lung protective ventilation in COVID-19 patients and how to select ventilation parameters individualized to suit the particular patient. We will also address the question of whether to PEEP or not to PEEP, and finally, the role of the non-invasive respiratory support. And now, just a little housekeeping before we get started. During this webinar, the audience will be in listen-only mode at all times, but we still are very interested in hearing your thoughts. So feel free to submit any questions you might have during the course of these presentations. You can use the question box in the Teams control panel on the right of your screen. Our speakers will try to answer you after their presentation. Some of your questions will be selected by our moderator for answering in the question and answer session at the end of today's webinar. In order to see if everything is really clear, I'd like to ask you to tell us, where are you joining us from? Just type in your name and country in the question and answer box on the right-hand side of your screen. Let's see, where are you coming from? Okay, brave hearts. Let me see, where are you coming from? Okay, I see some guests are coming. For your information, a recorded version of this webinar will be available in a few days. The link will be sent by email to all of you by the end of this week. Feel free to share it. Before we start, I would like to thank you all for joining us. We are delighted to have more than 1,000 participants for 95 countries. And now it's time to get started. I would like to introduce today's moderator from France, Dr. Jean-Michel Arnal. Jean-Michel?
Thank you, Branka, ladies and gentlemen. Welcome to this webinar. So thanks to all of you for joining in direct live. And I want to thank also our speakers for making them available for this webinar, and Hamilton Medical for organization. So today in November 2020, we have very little evidence how to manage COVID-19 patients, but we have a lot of experience. And the 3 speakers of this afternoon are very experienced because they were deeply involved in managing this patient. When I say deeply, it's also deeply in the night. I mean, it's not only a day work. It was, I know, very difficult. So we are lucky to have them this afternoon. And the first speaker will be Philipp Bühler. Philipp is a senior consultant in Zurich Medical University, and he has been very deeply involved in the last weeks and months. So Philipp will speak about lung protective ventilation in COVID-19. Philipp, please.
I have switched on my microphone. Do you hear me? Thank you very much, dear Branka, dear Jean-Michel. Thank you for invitation to this webinar today and the opportunity to present the individual ventilation strategies and considerations from Zurich. In the next 20 minutes, I will describe you how and why we performed individual ventilations in COVID-19 patients. I have no relevant conflicts of interests. First of all, for better understanding, I would like to mention this figure from Shear et al. It was published in BJA a few weeks ago in 2020. I would like to mention different stages from coronavirus disease. The disease begins with an incubation phase, followed from rearidemia, and mostly COVID-19 patients present asymptomatically or with mild symptoms. Only a small percentage for severe cases progressing towards organ dysfunction is of importance, especially in the phase 2 and 3. You see it here. 2 and 3. You know from the paper from Gattinoni, there's the type L phenotype and the H phenotype. With pulmonary manifestations under the underlying endothelitis and the inflammatory and coagulatory dysregulation lead to severe course that requires admissions at the intensive care unit. Possible intensive care support in these phases lies in the supportive application of oxygen. You see it here, and invasive or non-invasive ventilation or high flow therapy. And in the very severe cases, you need rescue therapies from INO or at least an ECMO are applied. Marini and Gattinoni describe it in their letters that hypoxemia and subsequent increased inspiratory effort lead to a vicious cycle. The pathophysiological changes caused by a virus caused hypoxemia. You see it here in this cycle. The viral disease leads to pulmonary dysfunction, recruitment of human cells, either by direct viral infection of the endothelium or immune-mediated, and can result in widespread endotheliitis and consequently alveolar dysfunction. This leads to a virus inspiratory effort in this part. With the consequence of the increased minute volume and more negative interthoracic pressure with little notion and deep dyspnea. The increased negative interthoracic pressure and the high tidal volumes lead to edema due to inflammation and increased endothelial and further alveolar permeability. This leads to dependent atelectasis and increased volume of breathing. Submission caused increased volutrauma, barotrauma, atelect trauma, and biotrauma, and aggravate the initial insults. What is known as a PCL, you see it here in the middle of this circle. And the ventilator-induced lung injury. As a result, the vessel stretch increased and leads to an increased edema, which get more power concentration of part of our lungs and makes a baby lung shrinkage, and worsening the hypoxemia, and the cycle was closed. In our experience, vicious cycles can be reduced or broken by the right intervention at the right time. For example, recompensation with high flow, perhaps with non-invasive ventilation, or with the right time point from intubation and mechanical ventilation in this part. This leads to a better outcome by allowing presence to recompensate from the L-type to the age type. Okay. In addition, to be correct, intensive care interventions, oxygen application, high flow therapy, non-invasive ventilation, intubation, and invasive ventilation. So following points are of particular importance. The right PEEP management to prevent de-recruitment, attention in obese patients or patients with decreased chest wall elastance, control of oxygen and ventilation with permissive targets, prevent mechanical overpowered, and avoid increased effort and work of breathing. You see it here. So precise evaluation of measured static compliance as a surrogate parameter from transpulmonary pressure. So continuous evaluation of mechanical power, recruitment, de-recruitment, chest wall elastance, and uncontrolled spontaneous breathing with the required continuous adjustments of ventilation settings show an important and individualization ventilation. So all measurements severe to present ventilator-induced lung injury. The aim is to ventilate the lung as physiologically as possible and to prevent second damage in the lung to the lung by ventilation. Based on the literature ARDS, the current valid stages of lung protection ventilation have been applied. Currently, the literature, it is still unclear where the best PEEP is. However, we will learn new concepts for this from my colleague in the following sessions. In our experience, we initially applied to evaluated PEEP levels, especially in the L type, and notice over the course of time that especially in the early phase, PEEP has been limited between 8 to 10 millibar or measured, assessed by means of PEEP titration or an esophageal probe. In the H type phase, higher PEEP levels are often to be applied. Based on the current literature, plateau pressure has been limited to the maximum of 30 centimeter water. If possible, measurement is inspiration hold. We predominantly used intelligent ASV in all COVID-19 patients and achieved a tidal volume of around 7 milliliter per kilogram ideal body weight. Compared to the lung safe study, this is current certainly acceptable, especially in the lung in the L-type phase. More liberal management of tidal volume, especially up to 8. You see it in this lung safe study. In severe ARDS patients, they get tidals around 7.5. Should be applied with regard to mechanical power and frequency compensation. According to the current findings, the focus should be more on driving pressure. You see it in this publication from Ahmad from the New England Journal. I think everybody knows this publication from New England Journal. The multivariate relative risk of death in the hospital increased by driving pressure higher than 15 centimeters of water. Based on this data, this maximum limit should be applied to your patients. Breathing rate was kept as low as possible, optimal below 25 per minute, especially because the breathing frequency has considerable influence on the mechanical power. There was no fixed PaCO2 target in our patient. We target a pH higher than 7.25. All these individual targets values can be well summarized in the concept of mechanical power. There we get a target below 17 joules per minute. Based on the publication from Gattinoni with mechanical power, you see it in the in this formula. With the OTIS and the MEET formula, much of this work of inspiration is covered by the Intelligent ASV 1.1, especially because the breathing frequency has a considerable influence on the mechanical power. This combined with the simplified mechanical power formula can be used to continuous evaluation. Now, from theory to daily clinical practice, how individualized ventilation was performed in Zurich. Now to the questions why we used Intelligent ASV in critical ill COVID-19 patient. We used Intelligent ASV in all critical ill COVID-19 patients if resources were available. Background from this decision is the continuous adaptation of the ventilation and oxygenation settings and the continuous change of the conditions based on the collected surrogate parameters SpO2 and entitled CO2 values. The validity of these continuous values are regularly validated by invasive measurements in arterial blood gas analysis. Furthermore, the ventilation is based on a minimal work of breathing with the OTIS formula and the MEET formula. This is calculated individually breath by breath. Another reason is precise pre-settings of oxygen and ventilation targets make it easier to use and primary work even for inexperienced employees. And the last one, the continuous machine adjustment with the presetting minimized the work and the time at the mechanical ventilator. And you can use the time for other things what you have to do to your COVID-19 patients. For understand Intelligent ASV is not intelligent automatic ventilation. It also required continuous supervision and controls. Intelligent ASV in critical ill patient can only be successful as a part of a lung protective bundle. Shortings in the Intelligent ASV are measured of a dynamic parameters. These can be adjusted by manual measurements of the inspiratory and expiratory hold maneuvers. Also, the ARDS network PEEP table overestimated the PEEP, especially in the L-type COVID-19 patient, and required a limitation. An evaluation of the recruitability of the implementation of the requirement maneuvers can significantly improve the conditions of the lungs. Reduce inspiration effort during spontaneous breathing during peracute phase should be avoided. If in doubt, we performed the transpulmonary pressure measurement in Zurich to get a better overall impression and to better understand to the difficult breathing situation. Now to our ICU concepts. Our ICU concept is based on the other therapies currently discussed in the literature. I repeat it, our standard ventilation mode is Intelligent ASV in all COVID-19 patients. Prone position was performed in patients with PF ratio below 200 millimeter of mercury, ideally early in the course of the diseases. Patients in the early phase receive a lung at rest strategy with PF ratio below 150 millimeter of mercury. Here, neuromuscular blockade is considered early. High flow therapy, you see it here in yellow, is performed with intermittent close monitoring of the inspiratory effort. There is a risk of missing the right time point for lung protective ventilation, and perhaps you increase the risk of patients have induced lung injury. The use of NIF, we you see it in red, was forbidden in our ICU in moderate to severe de novo hypoxemic respiratory failure, has also been consistently associated with a high failure rates of increased mortality, particularly when associated with tidal volumes greater than 5 milliliter per kilogram ideal body weight. Also, we use ECMO, and inhalated NO is performed as a rescue therapy if the indication is given. But the most important thing is to bring all the concepts into your team is teaching. Our ICU philosophy is teaching. All these measures only work in the context of an expanded teaching concept. For this purpose, we trained super users. This was the key role in teaching at the ICU and the consultant to conduct on a daily training bedside, and as a part of hands-on training, you see it here, and an SOP for ventilation was prepared and made available to all to the all staff. Difficult cases, you see it here, were discussed with the help from an online seminar with consultant and with colleagues from the clinical concept group Hamilton Medical. At this point, many thanks to Bernard Schmidt. What we teach additionally, we use a lot of more teaching units in this part. We teach way of measuring inspiratory effort, especially to prevent PESILI. We teach clinical signs of increased inspiratory effort. We teach the P0.1 value as in my opinion, a little bit bad parameter to the increased respiratory pressure, and we increase modern concept of a pressure muscle index, who was published from Belani in 2019 to evaluate the inspiratory effort in spontaneous breathing patients. Also, we evaluated and taught the PV tool to looks for recruitment and de-recruitment in all the patients. Concept of mechanical power was taught, and compliant measurements in controlled and spontaneous breathing patients. You see it here. Volumetric capnography, and at least in unclear cases, or in a situation you want do you want to know more about your patient, we use the effect pressure measurements. In summary, this teaching bundle could again significantly enhance the knowledge and the quality of ventilation. Unfortunately, in the first wave, we were not able to ventilate all patients with intelligent ASV from our concept due to the lack of capacity of ventilators with intelligent ASV. The team had to be deployed in 2 different intensive care units. You see it, we call this unit Süd 2B, and we call this unit BUF. This was the old trauma unit we reactivated for this pandemic patients. The team had to be deployed in these 2 units with 2 different ventilators, Hamilton S1 and Draeger V500. A special training and refresher course with Draeger 500 was performed. This gave us the idea to prospective compare the 2 intensive care subunits in 2 different ventilation modes. To specific consideration was due to the high number from patient intensive care units worldwide and overburdened, resulting in a lack of resources and expertise. Our thesis was closed loop ventilation as a fully automation and optimized ventilation mode could be associated with a higher degree of lung protective ventilation while reducing the number of manual mechanical ventilator setting adjustments in the ICU during COVID-19 pandemic. First of all, in this closed loop versus conventional mechanical ventilation, COVID-19 ARDS, overall 47 COVID-19 patients from the first wave assessed to eligibility. We have to exclude 7 patients because they were ventilated with high flow and non-invasive ventilations. All invasive ventilated patients were randomized to either conventional ventilation group or closed loop ventilation group. 17 patients were assigned to the conventional and 23 patients to the closed loop ventilation. All ventilation data were evaluated minute by minute. Overall, 728 ventilation days were monitored minute by minute on lung prospective ventilation. Criteria of lung protection were peak pressure below 30 centimeters of water, tidal volume below 8 kilogram per ideal body weight, and driving pressure below 15 centimeters of water and mechanical power below 17 joule per minute. All patients had severe ARDS. You see it here in the PF ratio around about, the median of PF ratio was 92. This and the subscores overall was 36. The mortality rate of all this patient was very low. The mortality rate overall the first wave was 20%. There was no ventilator related deaths. Okay, now you see the results. You see overall closed loop ventilation was superior in lung protective ventilations. The reason for this was particularly superior in terms of respiratory rates. You see it in this picture. You see all the parameters which we have measured for lung protective ventilation. You see here peak pressure in the first week. And you see here the PEEP, you see the respiratory rate, and you see the tidal volume, the driving pressure, and the mechanical power. And the blue line is the conventional ventilation group, and the red line is the closed loop ventilation group. And you see it especially in the respiratory rate. Was superior in lung protective ventilation in the closed loop ventilation. And another example was the driving pressure was significantly increased in the closed loop ventilation. And last one was the mechanical power was significantly increased too. If you see this slide, then you see in blue one, you see the conventional group, and the red one is the closed loop ventilation. You see this spider diagram to 100% of time, and 0% of time is in the middle here. And you see the values for lung protective ventilation. You see the mechanical power, the driving pressure, the peak pressure, the tidal volume below 8 milliliter, and the tidal volume below 6 milliliter, and the SpO2 rate above 88%. Overall, especially in the first week of the COVID ARDS, closed loop was associated with a 179% more time on lung protective ventilation compared to the conventional ventilation. Based on the results of our study, we demonstrate the successfully of closed loop ventilation in achieving lung protective ventilation when compared to conventional group. Now you see these boxes, the blue and the red boxes. The blue one is the conventional group and the red one was the closed loop. Already compared to the lung safe study, and a new study was published in Lancet Respiratory Medicine by UNED, also time rating intensity of mechanical ventilation and mortality in patients with acute respiratory failure. Already in the control group, you see it here, of the conventional ventilation, we could show that the superiority of our nurses and doctors. You see it to the mechanical power. We have 15% to ONET, always 49.5%, and in the lung safe study, we have 93% over time. You see it here from tidal volume below 8 versus 66% overall in the lung safe study. Nevertheless, intelligent ASV still shows a superiority to this group, to the conventional group, especially in the parameter of peak pressure, driving pressure, and mechanical pressure. Overall, values between 80 and 90% from time in these times. Okay, now to the conclusion. In summary, I would like to endorse the words of Sanile and Gattinoni. The key rule of intensive care is to provide support, buying time for patients to heal spontaneously. And with the words from Hippocrates, primum non nocere, first do not harm. The use of an extended bundle with intelligent ASV for an individualized lung protective ventilation may be the key to treat severe ill COVID-19 patients. Thank you very much for your attention.
Thank you, Philipp. Thank you very much. So quoting Gattinoni, I think, is a good transition for the next speaker. The next speaker is Francesco Mojoli. Francesco is professor in the Medical University of Pavia. And as you know, Pavia is part of Lombardy, this region that was very hard hit by the pandemic. So Francesco will tell us about PEEP setting during COVID. Is it different from other ARDS? Please, Francesco.
Thank you, Jean-Michel, for introducing me, and thank you all for attending this webinar. I have to speak about PEEP setting in COVID-19 ARDS. So I think that if this is the topic, it's normal to start from an idea of Luciano Gattinoni. Someone could say it's mandatory to start from this. You have already seen this. Gattinoni suggested two different phenotypes of COVID-19 pneumonia, type L and type H. These two patients have both a very severe hypoxia. PF ratio is below 100 in both cases, but very, very different respiratory mechanics. Type L means low elastance, low lung weight. That means a small amount of not aerated lung tissue and low recruitability. Whereas type H means high elastance, high lung weight, and high recruitability. Because the reason for hypoxia in type L COVID-19 is probably to be located at the vascular side. It's quite clear that high PEEP level is not indicated, but in this patient we have to see the moderate to low level of PEEP. This is consistent with the fact that patients with a low potential for lung tissue recruitability also show a smaller amount of non-aerated lung tissue compared to patients with a high recruitability that positively respond to high level of PEEP. The Gattinoni concept and idea can be translated into clinical practice using this threshold in compliance. So Gattinoni suggested to consider an easy number to obtain at the bedside, the value of respiratory system compliance, to distinguish type L and type H. A compliance of 40 or higher, that means that our patient is type L. A compliance lower than 40 means that our patient is type H. And this is probably consistent with the way we compute compliance. Compliance is the ratio between the volume increase and the pressure increase in the alveoli, and is proportional to the number of patent alveoli that are ventilated. Okay, so the larger the amount of not aerated, consolidated lung tissue, the lower the number of patent alveoli, the lower as well the value of compliance. This is the reason why the compliance of the respiratory system is very well correlated to the size of the baby lung in ARDS patients. That means to the residual inflated lung in this patient. So in the end, a pragmatic approach was suggested. Just look at the compliance of our patient and select PEEP accordingly. If compliance is almost normal or only slightly decreased, is higher than 40 ml per centimeter of water, select a low, medium level of PEEP, whereas if compliance is low, you are facing a type H COVID-19. In this case, we have to select higher PEEP because the patient is highly recruitable. Anyway, when this pragmatic approach was applied at the bedside, it came out that it is not that feasible. This is from Marcus Schulz's group in Amsterdam. They measured the amount of poorly aerated and non-aerated lung tissue with semi-quantitative CT scan and compliance as well. And then try to classify patient as H or L phenotype. And as you can see, they were able to classify as H or L phenotype only few patients that were patients in which compliance was low and the amount of poorly and not aerated lung tissue was 50% or more. And very, very few patients, just 2 patients, were classified as L phenotype, having a high compliance or normal compliance with 25% or less of poorly or not aerated lung tissue. But the very interesting result of this study is that it was not possible in the majority of the patients to classify into H or L phenotype. And this was particularly the case for several patients showing a high compliance, sometimes very high, with associated with a large lung involvement, with a large proportion of poorly and not aerated lung tissue. How is possible that such a patient with so severe lung involvement has a normal or even higher than normal compliance? The explanation is quite simple, and it's obvious that if you set a moderate low level of PEEP that is not able to stabilize the alveoli to avoid expiratory derecruitment, the tidal change in volume can be much higher than if you set a appropriate level of PEEP able to stabilize the alveoli and avoid expiratory derecruitment. So the message is that when we have tidal opening and closing, tidal recruitment, the alveolar snap opening is associated with larger changes of volume and higher compliance than a condition with a PEEP setting able to avoid expiratory derecruitment. These are 2 pressure volume curves obtained in the same patient starting from ZEEP, zero end expiratory pressure in red, or starting from a PEEP of 10 centimeters of water. You see very different shape of these 2 curves. Starting from ZEEP, there is an S-shaped curve with a lower and an upper inflection point that is associated with progressive recruitment of lung tissue that was derecruited, going down to 0 end expiratory pressure. If you start from a PEEP level that is able to avoid expiratory derecruitment, the relationship between the volume and the pressure increase is completely different, is now linear. And what is really interesting is that if you compute compliance in the same pressure range between 10 and 30 centimeters of water, you see that the compliance value is much higher, is the slope of this relationship is much higher when you start from ZEEP than when you select the optimal level of PEEP. So it's not that surprising that several patients with a diffuse loss of aeration in their lungs at a normal or even higher than normal compliance due to tidal recruitment. So probably we have to introduce a new subphenotype of COVID-19 disease that is what I call type U, where U stands for unstable lung. So in case of a diffuse disease, if you set a PEEP that is not able to avoid expiratory derecruitment, you see tidal recruitment, and this is associated with a very, sometimes with a very high compliance. And probably we have to even more than 3 phenotypes in COVID-19 patients, because for instance, in type H with a large proportion of consolidated lung tissue, we observed both high and low recruiters. So this pragmatic approach that started easy and feasible is becoming more and more complex. So I think it's better to go back to a general rule that is in acute hypoxemic respiratory failure patient, PEEP should be set according to recruitability. In patients with low potential for lung tissue recruitability, we have, of course, to set low PEEP level, because otherwise we have just side effect of high airway pressure. That means an increase of alveolar stress and strain in the non-dependent part of the lung. Whereas in patients with high potential for lung recruitment, an increased level of PEEP is associated with a decrease of the non-aerated lung tissue, and more importantly, with a decrease of tidal recruitment. So a decrease in the difference between the amount of non-aerated lung tissue that we see at end inspiration compared to end expiration. And this is important because recruitability is not an opportunity for our patient, it's a risk, because we know that with the increase of recruitability, this is associated with a progressive increase of mortality in ARDS patients. And mortality seems to be more correlated with the opening and closing lung tissue than to alveolar strain, at least in the era of low tidal volume ventilation and plateau pressure limitation. This is probably the reason why it is in this subgroup of patients, those patients showing the highest recruitability, that setting a high PEEP level makes the difference in terms of survival. So my answer to the question is that in COVID-19 patients, we have to use the same rule as for, let's say, normal ARDS, that is setting PEEP according to recruitability. And of course, CT, quantitative CT, is the reference method to assess recruitability in ARDS patient, but a clinical approach, everyday clinical approach based on CT is clearly not feasible. we use lung ultrasound assessment at the bedside. This is a COVID-19 patient with almost all lung regions with normal lung aeration, lung tissue aeration, just some B lines in one posterior lung region. So if you like phenotyping COVID-19 patient, this is a type L patient. This is typically a PEEP non-responder patient. So we set low PEEP value in this patient, and we use innate nitric oxide as rescue treatment. This is a completely different scenario, looking at anterior, lateral, or posterior lung regions. Everywhere you see multiple coalescent B lines. This is severe diffuse inflammatory lung edema. Again, this is the unstable COVID-19 patient. Is usually highly recruitable. So we set high PEEP in this patient and we use proposition as rescue treatment. And this is the type H patient with almost normal ventral part of the lung and consolidated dependent lung regions. In this patient, we use by default proposition, and we set PEEP according to a, let's say, quantitative assessment of recruitability that we do at the bedside with this tool, the pressure volume curve, because you know that the hysteresis, that is the area enclosed between the inspiratory and the expiratory limb of the curve, is well correlated with the volume of recruited lung tissue. This was very recently validated against the reference method, that is the quantitative CT. Another tool you can use is electrical impedance tomography. I think it's a very, very interesting bedside tool to assess recruitability and select PEEP in ARDS patients. What you have not to do, in my opinion, is to use compliance to set PEEP. Compliance is a very important parameter to assess our patient and monitor disease evolution in our patient, but it's now clear that it's not the right way to set PEEP. It's now proven. So to conclude, PEEP in COVID-19 patients should be set according to recruitability, as in all the ARDS patients. In recruitable patients, we have to set high PEEP level, trying to keep positive value of expiratory transpulmonary pressure and avoid de-recruitment, whereas in non-recruitable patients, moderate low levels of PEEP are okay. Compliance, respiratory system compliance, does not predict recruitability. There are several ways to assess recruitability in our patient. Use the technique you are confident with. And what is special to me in COVID-19 patient is this strange combination between high compliance and high recruitability that is not common in ARDS patients, whereas is very common, at least in my experience, in the very early phase of severe COVID-19 patient with diffuse severe inflammatory lung edema. Thank you for your attention.
Thank you, Francesco. Thank you very much. This type U is a new information for most of us, I guess. So now we will finish with the last speaker. That is Oriol Roca. Oriol is a senior consultant in Vall d'Hebron Hospital, which is a university hospital in Barcelona. And Oriol will speak about non-invasive management of COVID, and especially high flow nasal treatment in COVID. And he will tell us 3 messages. Please, Oriol.
Thank you. Thank you very much, Jean-Michel, for the introduction. And thank you for the invitation and all the attendees to be here. I'm trying to share my screen. See if I could do it. Can you see now the, sorry. Yeah. Can you see now the presentation? Can you see it?
Yes, we do.
Yeah, okay, perfect. So thank you very much for being here, and I would try to summarize 3 things that we should keep in mind when we are using non-invasive respiratory support in COVID-19 patients. These are my conflicts of interest, and I also have my own bias, which is that I work in a hospital in Barcelona, which since 2007 we have been using high flow much more frequently than NIV. So I have to recognize my bias. Well, before the COVID came, we had 66 ICU beds, but during the first wave, we increased our ICU bed capacity up to 200 beds. And this allowed us to treat, during the first wave, 342 patients, and to admit also those patients who were treated with high flow and were more at risk to be intubated. In fact, we almost treat 150 patients with high flow before starting invasive mechanical ventilation. And in fact, we only had to start this therapy in 34 of these patients, which is more or less the 50% of the patients that we treat with high flow. So this is the structure of my talk. Very easy. The first, the second, and the third thing. And if we look to the guidelines regarding the recommendation of the use of high flow or NIV are sometimes confusing, and even they could send us different and opposite message, in particularly regarding the use of NIV. But I would say, as a first thing, that the benefits and harms of non-respiratory supportive therapies in COVID-19 patients might not be different to those previously described in other types of acute hypoxemic respiratory failure. And in this figure, you can very nicely show which are the effects, the physiological effects of high flow. I have to say that all the effects are flow dependent, which means that the higher the flow, the higher the effect you have. And the main difference of high flow compared with other techniques is that it's extremely comfortable. Despite all these mechanisms, the relative contribution of each one is still unknown. And the effect of high flow is highly heterogenic and varies among patients and varies in the same patient in 2 different times. What seems very clear is that high flow may interrupt the vicious circle of patient self-inflicted lung injury at different levels. It may decrease esophageal pressure swings, it may improve gas exchange, it may decrease respiratory drive, and at some point, and in some patients, it may interrupt this circle and avoid the need for mechanical ventilation. as I told you a couple of slides before, the main difference compared with all other techniques that I have tested is that it's extremely comfortable for the patient and easy to use for the healthcare workers. But we have to keep in mind that higher flows are more likely to be not tolerated, especially at the beginning of the technique. However, the comfort is a dynamic concept, and the patient might be more comfortable with longer use of high flow. So we will have to continuously titrate the flow to obtain, with the maximum tolerated flow, to obtain the maximum effect, and to try to keep the patient on high flow the more time possible. There are few encouraging studies that have been published about the use of high flow in COVID-19. This is a propensity score matched analysis of some patients admitted in, if I'm not wrong, 5 different hospitals in Paris by Alex Demoule, that was published in the Bull Journal last month. They matched almost 140 patients treated with high flow with other 140 non-treated with high flow, and they observed that high flow was associated with a reduced proportion of patients requiring invasive mechanical ventilation at day 5. In fact, high flow patients require mechanical ventilation, 55% of them, which is very similar to the percentage that I showed at the beginning. And again, there were no difference in mortality as happened with the floral study, and it's, let's say, it could happen because mortality may be related with some other factors, especially in COVID-19 patients that present a lot of different complications like thrombosis or severe infections. Another interesting figure that has been recently published by the REVA network in intensive care medicine is this one that you can find in the supplementary material of the paper. And you can see how the different behaviors evolved during the first wave. At the beginning, we were a little bit afraid of using high flow or NIV, but as the pandemic evolves, the use of high flow and NIV was increased, and it was related with a decrease of the need of mechanical ventilation and even mortality. Of course, I'm not saying that this was only related with the use of high flow or NIV, because as the pandemic evolved, we also know that we should not use some treatments, and maybe you should use steroids, but I'm sure that this is part of the effect that we observe in the need of mechanical ventilation. And remember that a ventilator was a very precious device during the pandemics. NIV has also some benefits that I'm sure that all of you know, but I want to remember that in terms of hypoxemic respiratory failure, the novel hypoxemic respiratory failure, ERG and ATS guidelines could not provide any recommendation due to the lack of evidence. I only say that if you use, you have to be very cautious in monitoring exhale tidal volume. It's very difficult to control the tidal volume provided to the patient due to the high respiratory drive and the, even though you use low levels of pressure support. And it is important because these high tidal volumes have been associated with NIV failure or even higher mortality. And this monitoring is maybe a limitation of helmet interface, even though helmet interface has a lot of benefits, as we will see in the next slides. And coming back to the previous slide of the vicious circle of patient self-inflicted lung injury, NIV, at least face mask NIV, could even increase the pre-existing lung injury in some patients. So we have to be very, very, very cautious with its use. And I know that there has been some controversies between Luciano Gattinoni and Martin Tobin regarding the existence or not of patient self-inflicted lung injury, but I want to show you some data that suggests that it might be possible. Here you have some patients treated with NIV monitor with an esophageal catheter, and here you have the esophageal swing, and you can see that those patients who succeed with NIV present a decrease in esophageal swing, which means a decrease in inspiratory effort, maintaining the same transpulmonary pressure. By contrast, all the patients who fail presented no changes in esophageal swing, which means that they keep on the same inspiratory effort that they had before initiating NIV, and they increase transpulmonary pressure, which may increase the pre-existing lung injury. Another indirect data of the existence of patient self-inflicted lung injuries presented in this study that has been recently published in the Blood Journal. They were patients who were switched, they were mechanically ventilated, and they're switched to pressure support. They were COVID-19 patients. And as you can see, those patients who present a high respiratory rate were more at risk of relapse of the pre-existing lung injury and going back to assisted control ventilation. I talked about the helmet before. I think that this is I think that the Italians show us how to do it, and we have a lot of to learn of them about the use of helmet. This is a physiological study performed by the Domenico Luca Grieco and the group of Massimo Antonelli, and they compare high flow, the effects of high flow with helmet and AV. And as you can see, helmet in AV was associated with a better oxygenation, higher decrease in respiratory rate, and less dyspnea feeling. But more importantly, and we have talking about the esophageal decrease by high flow, but compared with NIV, the decrease in this esophageal pressure swing was even greater, with no changes in the transpulmonary pressure that we had. So if we go back then for third time to the vicious circle of the patient self-inflicted lung injury, and we had previously said that high flow was a good technique in order to interrupt this circle, maybe helmet could be even better. And maybe this partially explains the results of this single center study of the group of John Kress in Chicago that performed in ARDS patients where helmet NIV was associated with higher survival compared with those patients who were treated with face mask NIV. The second thing that I want to ask you, or that I want to talk about, is about the concern of there is an additional risk of viral transmission to healthcare personnel when using non-invasive supportive therapies. Well, the first data that we have when the pandemic starts is related to SARS-1. And what we knew then is that high flow was not associated with a higher risk of transmission to healthcare workers, which is not the same situation that face mask NIV and trachea intubation had at that time. And it is clearly explained or partially explained if we take into account the exhale smoke dispersion of different oxygen devices. Here you can see the dispersion distance of different flows with high flow compared with conventional oxygen, and with high flow even is less the dispersion that we have. But what I strongly recommend is that if you are using high flow, you may put a surgical mask on the top of the cannula of your patient. And this is clearly shown in the figure that you have on the right of the slide here. There are different flows, 46, and even with no kind of respiratory supportive therapy, and you can clearly see the amount of exhale smoke dispersion, which is completely avoid with the use of surgical mask. But it is not important. It is not only important in terms of healthcare personnel transmission, but also in terms of oxygenation. This has been recently published in Annals of Intensive Care, and as you can see, when you place a surgical mask on the top of the cannula, oxygenation clearly improves, and it clearly drops the SpO2 when you remove the surgical mask. So at this point, it could also be beneficial. And what happens with helmet? The leaks that we have with helmet are completely different than the ones that we have with face mask NIV. And I would compare helmet in terms of smoke dispersion to the smoke dispersion that we have with high flow and surgical mask on the top, even when you are using high level of inspiratory and expiratory pressure. So it seems at least as safe as high flow and surgical masks. And in fact, in the studies that we have with SARS-CoV-2, the environmental contamination was not associated with the day of illness, the ventilatory mode, or different aerosol generating procedures, or even viral load. So it is not clear. And my last slide about this issue is this very elegant study that compared different respiratory supports from room air, nasal cannula, face mask, high flow at different flows, and NIV with different settings in 10 healthy volunteers inside negative pressure rooms. And what we can see is that oxygen delivery modalities, and I mean high flow or NIV, do not increase aerosol generation. What increases aerosol generation is coughing or changing in respiratory patterns, especially those particles that were smaller. The third thing which I think that is important is that early intubation in those patients who fail may be associated with better outcomes. And in other words, late intubation is associated with worse outcomes. But I don't like the word late. I would say delayed intubation rather than late, because they are slightly different. But it has been shown in NIV some years ago. It has been again shown in patients with high flow. So it is very important to monitor very closely these patients. Here there are two patients with two lobar pneumonias, one in the left lung, one in the right lung, with the same SpO2, FiO2, but if we look to the patients, they look extremely different. One is intubated for aspirative pneumonia, monitored with EIT, treated with NO, with esophageal pressure, and the other one only brings SpO2 measurement and non-invasive arterial pressure. I'm not saying that this patient needs more monitor than that. I'm saying that this patient is severe and we have to look at him in order to detect any clinical deterioration as early as we can. And there are a lot of variables associated with high flow failure. I will not go deeply on that because I know that you probably know them, but I will only want to show some data about the ROX index for high flow, which we defined a couple of years ago. It was defined as the ratio between SpO2 and FiO2 and respiratory rate, and interestingly, it outperformed the diagnostic accuracy of these two variables separately. In fact, a ROX index above 4.88 at 2, 6, or 12 hours after high flow onset was consistently associated with a lower risk of mechanical ventilation, even after adjusting for potential confounding. But we also define some thresholds for failure, not only for those patients who are going to do well with high flow. And these thresholds were highly specific at different time points. So between the threshold of no risk and the threshold of high risk of intubation, there is obviously a gray zone. And for the amount of patients that are in this gray zone is relatively low, only on 11% of the entire core that we had on the valid ROX validation study, and the intubation rate of this 11% of the patients was more or less the same that the rest of the core had. But what we have to do with these patients? So if you reassess the ROX index and you calculate the delta ROX, you will see that is also different between those patients who succeed, where the delta ROX increase over time, or those patients who fail because these patients, the delta ROX remains constant or even decrease. But the obvious question that arises is what occurs first, the traditional criteria or the ROX criteria, because if they are at the same time, the ROX does not provide any benefit. And here you have represented the percentage of patients that did not meet the traditional criteria for intubation, and they had a respiratory rate below 35, but they met the ROX criteria for intubation at 2, at 6, and at 12 hours. What happened with these patients that were not intubated at 2, at 6, and at 12 hours because they didn't meet the traditional criteria? Almost 90% of these patients were finally intubated. So if we had used the ROX criteria, we had intubated them earlier. And the other obvious question is 12 hours a safe zone to be sure that you are not delaying a needed intubation? And the only way that we had to test it is compare the relative risk of death at different times, taking as a reference the mortality of the patients that were intubated within the first 6 hours. And what we observed is that at least before these 12 hours, there is no additional risk related with the time of intubation. So the proposed algorithm with the data that we have, and is an algorithm that we are going to test in a randomized controlled trial, is this one. The algorithm is exactly the same at 2, 6, and at 12 hours, and the only difference is the threshold that you have to use to consider intubate the patient. If the patient is in the gray zone, you always have to increase the support and reevaluate in 30 minutes, and then calculate the delta ROX. And according to the result of the delta ROX, you always take the decision to intubate if there is no improvement, or you can keep the patient on high flow if there is some kind of improvement. Interestingly, the ROX index has also been tested in COVID-19 patients, and the threshold is more or less the same. Remember that there is the respiratory rate of COVID-19 patients is probably slightly lower than the patients with bacterial pneumonia, and this feeling of dyspnea, it's more or less the concept of happy hypoxemia came at the beginning of the pandemic, and maybe this slight difference in the threshold are due to this fact. But if you don't want to go to the index, you can also look at the separate variables, because oxygenation has also been related with a higher incidence of failure of high flow. And if you look to respiratory rate per separate, you also will find similar results that the ones that you observe with ROX. Interestingly, the thresholds that have been described here with COVID-19 patients are very similar to the ones that we described in non-COVID patients. And what happens with NIV? With NIV, we can use the HACR score. The HACR score is a composite score that is calculated using the heart rate, the pH, the Glasgow Coma score, the PaO2, FiO2, and the respiratory rate. And as you can see, those patients who failed had a higher HACR score compared to those patients who succeed. And the authors describe a cutoff of 5 to predict those patients who fail. And when they compare those patients who had a HACR score higher than 5 after 1 hour of NIV, and they compare those who were intubated early versus late intubation, taking as a cutoff the 12 hours, they observed that those patients who were intubated lately had a higher mortality. So it seems that is a score that could be very useful in NIV patients. But of course, the use of different kinds of non-invasive supportive therapies is most of times limited by their availability in terms of a pandemic. But my recommendation would be that the intubation criteria would be clearly predefined before starting the non-invasive respiratory therapy in order to not delay any intubation in those patients who are going to fail. And there are several unresolved issues that I don't have the answer, such as if there is any technique superior to other in terms of need of mechanical ventilation or mortality, which patients would benefit the most, the right moment to escalate the therapy, or even the real effectiveness of awake proning, something that we have done, but I could not address in this talk due to a question of time. So in summary, I would like to summarize that some patients with COVID-19 may benefit from non-invasive supportive therapies. Data regarding the risk of viral transmission to healthcare workers is scarce. However, when you use non-invasive supportive therapy, the use of adequate PPE and HEPA filters in NIV are mandatory, and these patients supported with non-invasive supportive therapy need to be closely monitored to detect as early as possible any clinical deterioration. Thank you very much, and I would be very happy to take any questions.
Thank you, Oriol. Thanks, the three of you. Clap, clap, clap. Great talk, great presentation with new information. So I like it very much. We have a few minutes for questions. So I will ask you short answers so that we can cover as many questions as possible. So Philipp, you have a question. How did you manage patients with very low compliance using IntelliVent ISV? Philipp, can you activate your microphone?
Yes, I have a little bit technical problems now. Sorry. Yes, we managed patients, especially high type COVID-19 patients with a very low compliance were also a big challenge for us. Often we use transpulmonary measurement in these patients with their help, especially in driving pressure, plateau pressure, and PEEP could be optimized. A frequent problem was also the limitation to restrict ASV limits. So we increased the ASV limit in the combined with the measurement from the esophageal measurements. Also a manual control of a minute volume percent was successful and helps us, and all patients were controlled according to a pH through 7.25, and yeah, this was the answers in this question.
Okay, and another question about the use of IntelliVent ISV is how often did you abandon IntelliVent ISV and for what reason?
Excuse me, the quality was very bad. Can you repeat?
Sorry, how often did you abandon IntelliVent ISV in this patient? Did you have to switch to another mode sometimes? And for what reason?
Yeah, mainly we switched to other patients who, if we installed extracorporeal membran oxygenation mainly, and or we leave lung protective ventilation, but mainly it was no reason to switch, and we have the most problems we have was recent what not combined with respiratory problems. It was combined with coagulopathy, and we have a lot of lung embolism patients and brain ischemia patients. So this was our main problem with endotheliitis, and not a respiratory problem.
Thank you, Philipp. Francesco, thank you for the type U. You have one question about can we assess recruitability in prone position?
Yes, you can assess recruitability whatever the position of the patient. Of course, it could be more complex if you do it with lung ultrasound, because the anterior regions of the lungs are not available. But in prone position, actually, is important to detect the recruitment of the dependent part of the lung, and the amount of the recruitment in this zone is actually associated and correlated with the response to prone position. If you use the PV tool, to me there is no difference. I'm not aware of different thresholds for supine and prone, for patient in supine prone position, when we look at the hysteresis in the pressure volume curve. But I think that should be the same. And I never perform a CT scan with a prone, with a patient in prone position, but Luciano Gattinoni did, so it's possible.
Okay, thank you. And what about recruitment maneuver? Do you think that we should use recruitment maneuver in COVID patients? And one question is, in case of yes, do you use recruitment maneuver also in prone position?
Yes, usually we perform a recruitment maneuver early after intubation in this patient. And after the recruitment maneuver, we perform a sort of decremental PEEP trial. The second question was about the recruitment maneuver?
In prone position.
Yes, it's not only possible, but also safer to perform a recruitment maneuver in prone position. At least for the possibility to injure the lung.
Yeah. Okay, thank you, Francesco. Oriol, there is a question. Patients on NIV have often desaturation due to care or eating. And I've noticed this also in high flow. I'm surprised to see that even if the patient has 60 liters, when they talk or they eat, they desaturate. So any data whether this desaturation have impact on outcome?
I'm not aware about any study that reports that, but I don't like patients with 60 liters and FiO2 of 0.5 or over 0.5, let them to eat, because at the end it's an effort and you don't know exactly how at least during the first 2 days of evolution of COVID, because you don't know how this patient will evolve, and if you have to intubate them, then you may have a bigger problem. So I would say that this very little effort, which is eating, I would try to avoid at least during the first day, especially when these patients are highly supported with non-invasive respiratory therapies. Otherwise, the risk of failure is much greater.
Okay, well, it's going to be difficult to convince French patients not to eat, even if they have 50% of FiO2. They will kill me. Oriol,
if we have do it in Spain, you can do it in France for sure.
Okay. Do you use sometimes high flow in prone position?
Yes. In fact, we are participating in a randomized control trial and in a meta trial of 6 randomized control trials, one in US in Chicago, other in France by Stefan Ehrman, other in Canada, or another in Ireland, another in Mexico, that by the moment have included more than 400 patients as the whole 6 studies. And we have no data about the effectiveness of awake proning apart from an improvement of oxygenation in some patients. But when we had no ventilators and we had a lot of patients and we had to treat a lot of people, we did things that are still unproven in terms of efficacy, but we are testing now them. And we have used it. I guess that my colleagues also will have used it as well.
Okay, thank you. The last question will go to Philipp. Philipp, there are a lot of people that have Hamilton ventilator and they have IntelliVent ISV, but they didn't have a chance to start using IntelliVent ISV before COVID. So would you recommend that they start now when they have COVID patient, or it's not the good time and they should wait and start with non-COVID patients?
Yeah, in my opinion, do you understand me very well? In my opinion, I think it's important that you only use IntelliVent if you understand IntelliVent ASV, and if you have the capacity to learn all about IntelliVent ASV and to learn how you have to change the controllers and do you understand the concept behind this mode, then it's a good time point to use IntelliVent in COVID-19, and you can reduce your workload in all the patients. You can control stuff which is not familiar with ventilation, and it works very well, and you can use IntelliVent ASV for better lung protective ventilation. I show it in my data from our study.
Okay, thank you very much. I think we have to close here. Thanks to the 3 speakers. It was really great talks. Thanks for all the participants for your participation and great questions. Now I will give the last word to Branka Cupic.
Thank you, Jean-Michel. We started this webinar by asking ourselves what lessons we have learned in the last 9 to 12 months. I think it's clear that at least one lesson was clear. There is no one-size-fits-all approach. So there is no one single magic recipe for treating COVID-19 patients. But I hope we've been able to answer at least some of your questions. Don't forget, we will be sending you a link to all the question and answers, including those we weren't able to answer during the webinar itself. I want to thank you once again for joining us today. I know you all have very busy schedules, but I'm sure that was worth your time. If you found this webinar helpful and you'd like to get more informative content and resources from us on a regular basis, I encourage you to subscribe to our Intelligent Ventilation newsletter. It is sent out every 2 months only. After the webinar, you will receive an email from us where you can sign up for that and any other newsletter from Hamilton Medical with just a couple of clicks. And if you're not interested, just ignore the email. That brings us to the end of today's webinar. We hope that to see you again at our next live event. Goodbye to you all from the team at Hamilton Medical. and stay well in the months to come. Thank you.